to the Bare Naked Shrinks.
Hello, and welcome to this episode of the Bare Naked Shrinks with me, Dr. Danny, and my amazing co-host, Dr. Courtney.
Hey.
And today we have our amazing friend and colleague, Dr. Jason Lavender. He is
Hello.
I have to read this. He's so fancy and special that he has a paragraph of a title, which is when you know you've made it. He is the associate professor in the Department of Medicine at the Uniformed Services University and the director of behavioral research for the Military Cardiovascular Outcomes Research Project with the Metis Foundation. Welcome, Dr. Jason.
Thank you so much to both of you for having me. I'm really excited to be part of your podcast and to talk about this topic today.
We're so excited that you're here.
So to start things off, let's get into our
cake and crap.
My cake is that it is officially fall, which in LA just basically means it's like 10 degrees cooler and maybe some rain happens. But my fall wardrobe includes, I have to do a visual for this, socks.
Ooh.
I have so many fun socks.
Oh, are those the party socks that you pulled out at ISED last year?
Party socks.
Love them.
Wait, let me try.
Nice.
Party socks. I have like I don't know how many pair. Sock candy.
You got a lot to the conference. I've been getting ads for sock candy on Instagram.
Maybe because of me.
Potentially.
I want them to sponsor me because I literally buy all of their socks and talk about them all the time. But I love wearing socks with sandals, and they're fancy and they're sparkly and they're colorful. And I just bought a new pair today. They have a mommy and me collection. So me and Lively are going to have matching ones.
Nice.
So I'm so excited. And then my crap, I've actually had a pretty good week. I would have said, so I got my hair cut. I got it chopped off like 6 inches. I would have said that was my crap because I ended up, the hair journey is the theme that keeps on giving this season.
Really has.
It got really damaged from all the BS I did to it. And so I had to chop it because it was so bad. But I am a short-haired girly, I think. Like I think I'm gonna keep this forever. It's so easy and it's fun. I feel very fun with it. And I have matching haircut with Lively too, so that's really cute.
Well, what a fun thing to discover through unexpected ways.
Exactly. It was very serendipitous. So yeah, I don't really have a crap this week. So Courtney, how about you?
Well, my crap this week has been that I was sick all week, which is why I'm in the office on a Friday, which is not typically where I'm at. So I was sick like Monday through Thursday and was sleeping and missed out on a lot of fun things, which was really a bummer. I was supposed to go see Kygo with some friends on Wednesday night, and Vandalux and Zara Larson were openers, and I got a lot of fun videos from friends that went, and I didn't go. I chose to be the responsible adult and take care of my body, and I'm still sad about it. So that is definitely my crap for this week.
Very proud of you, though. I know that is your kryptonite going out.
I know. It's been
kryptonite's bad. Is kryptonite bad or is that good?
Kryptonite is bad.
Okay, never mind. That's fine.
I don't know. But I do love going out and having fun. And the fact that I haven't been able to do anything exciting all week has been really challenging. And I'm ready to feel better and like have fun again. And I'm saving up my energy, resting this weekend because I want to have energy for next weekend when we're together in San Diego.
Oh my gosh. So excited.
I am so excited.
And Jason, I'm so bummed that you already have plans because we are going to have a blast.
I know. I'm very sad about that too, but I'll be there in spirit, and hopefully we can all see each other at the next ISED.
Oh,
definitely.
Of course.
I'll be there. So my cake this week is before I got sick. So last Friday, I think I had mentioned this as what I was doing last weekend. Went out to the Wild Rose lesbian bar in Seattle, where I spend a lot of time, and with all my new kickball friends. And we know that I love kickball now, and I've made some cool friends through kickball. And so a bunch of us went out and just like danced at the Wild Rose and chatted, and it was such a fun night. So that was definitely the highlight.
Awesome. All right, Jason, how about you? What's your cake? What's your crap?
So cake, I would say for this week for me has been, I just recently bought my first house, which was super exciting. And right now I'm getting to decorate for Halloween for the first time, or at least do some substantial decorations like outside and everything.
What's the vibe? What are you going for?
Fun. I gave this a lot of thought. So I thought about harvest. I'm not really a harvest guy. I do kind of like the goofy stuff, but I think like scary is my vibe. So most of the stuff that I've got is scary, but on a 6 to 7 of a 10 scale. Not super terrifying scary, but like scary ghosts and skeletons. So sort of a mix of scary stuff. And then I got a bunch of little skeletons that are adjustable and are like hanging off my address sign or waving from the gutter on the top of my house. So kind of scary, but kind of goofy too. So that's been pretty fun this week.
Did any of y'all see that Michaels did a whole line of lesbian colored Halloween decor?
Michaels, they're coming out against the religious Hobby Lobby.
We did. So
I was going to say, it's the anti-Hobby Lobby.
Exactly. Yes. So I had a great time and bought a lot of lesbian color themed Halloween decor. So now it's all over my apartment. It's great.
Fun. Well, I'm going to have to go check that out.
And crap.
Yeah, crap. So crap, I think for me is I was out of town last week and I was actually pretty effective, which is rare for me, at detaching from email, which is great for being in the moment and then means more to return to. So this week has pretty much been playing catch up and responding to tons of emails and feeling I can't quite catch up, but slowly making progress. So can't complain too much, but that's been the little bit of heightened post vacation stress with that, but nothing too terrible. So.
Yeah, that's rough. Leslie's was sort of the same thing because it is like whenever you have such a important and demanding job, vacation isn't fully vacation because you always got to make up for it.
Right.
So
Totally.
Feel that.
And in this case, normally I like sort of keep up with some emails because I kind of want to not have to face so much when I get back. But that's a trade-off with not being fully present in the moment and thinking about work more. This time I kind of turned it off, which was nice.
Totally. Okay, so we are going to have a new session called Confessions from the Couch.
Confessions from the Couch.
So basically, it could be anything, really. It's like anything that is weird or funny or just random. And it could be something happens with a patient, like when they're on the couch. It could be if we were in therapy, something weird happened. It could be just in our own life. Anything goes. I actually just came up with mine. So this isn't anything that had to do with patients. One of my friends, he moved here from New York. We met in Oklahoma at OU. He was doing like a research sabbatical thing as an undergrad. He went to Vassar and then he came to OU, and he's this gay Jewish man from New York City, and he was fish out of water in Oklahoma. And him and I glommed onto each other and have maintained a friendship for over 20 years. And he just moved back to LA. So last night we went to dinner, and things like this happen to me all the time. You know, I've told you about all the like, what is that? Synchronicity? Is that the word? So we walked down there and Ethan is having a smoke like the New Yorker he is. We're standing in front of the restaurant. And I see this really hip looking guy with shorts on and it says OKC Thunder. So I was like, oh, OKC Thunder. And I will talk to anyone. It does not matter. So I was just like chatting, and he was like, too cool for school at first. He was like, hi, girl that's like talking to me about my shorts. And anyway, so I just kept, just like I did with Leslie, I just door in the faced him. Finally, he softened up and we just started chatting. And I was like, what are you here for? He was like, oh, I'm just in town. And then a few seconds later, he was like, actually, I'm here with the Flaming Lips and they have a show tomorrow night. The Flaming Lips are from Oklahoma and live in Oklahoma. But I had seen the bus earlier that day and it said Kansas on it. So I was very intrigued. I was like, I want to see what band it is. And of course, I found out, then I'm talking to this guy, Zachary is his name, and find out he knows so many people I know. He knows all of my friends here in LA that are in bands. He was like, I'm friends with them. I didn't ask to go to the Flaming Lips concert. I kind of thought about it, but I was like, I need to go to bed at like 9 p.m. And then another cool thing that I found out, because the friend that he is especially friends, Zachary is especially friends with Josh, I texted Josh and I was like, look who I saw. And I took a picture with him and everything. And he was like, oh, I want to go. Like, I love the Flaming Lips, but I'm going to go see The Anniversary. And The Anniversary is a band from Kansas, and I am good friends with the lead singer. Matt and Josh are going to go to that concert tonight. So fun, little, cute, full world, Oklahoma, Kansas, LA connections. All right, Courtney, how about you? Confessions from the couch.
Confessions from the couch. Well, I did not do any clinical work this week. So I'm going to go back to one of my favorite all-time embarrassing clinical stories. I feel like I have so many like good embarrassing stories about me as a clinician when I was at UCSD. But my all-time favorite was my first year when I was an intern. It was on the adolescent rotation, and I was leading multifamily DBT for the first time.
And so are there parents and
so
kids?
Parents and kids are there. And Ana Ramirez is in the room. So I'm like so nervous, right?
Who is that? I don't know who that is.
She was a program manager at the time. So I was like definitely trying to impress her and like wanted to look like I was doing a good job. It was my first time ever leading DBT ever group. And then also my first time leading multifamily DBT in front of somebody that I like, wanted to impress. So we're practicing the observe skill and describe skill. And so we have these like puffer balls, those little balls that have all the spiky things on the side. So we used to have a basket of those at UCSD and we pass them around. And so when we're teaching observe and describe, we pass around the puffer balls and practice observe and describe with the puffer balls. Everybody gets a puffer ball. I'm like, we practice the observe and describe. Afterwards, I'm like, okay, so what was this like practicing observe and describe with the puffer ball? One of the adolescents goes, well, I noticed a hair on my ball. And I was like, okay, great. And then one of the parents goes, yeah, I also noticed some hairs on my balls. I say, well, besides the fact that we had some hairy balls, and I lost it. Like, I just could not stop laughing. Like, I don't know if y'all have seen me do that thing where I just get, like, I start laughing so much I can't control it. And so I could not recover. And everybody's laughing. And, like, Emily Conlin had to jump in and, like, start taking over and teach the laughter because I could not keep it together. I was, like, so embarrassed that I could not stop laughing.
I mean, were the group members laughing too, though?
Oh, everybody was laughing. But I was, like, uncontrollably, like, it was an issue.
This is your big emotions. Your big emotions. I love that story. All right, Jason, do you have anything? You totally don't have to, but.
Yeah, no. So I haven't done clinical work in a few years because I'm in an entirely research position right now. My confession, which is not really so much a confession as a wish, I suppose, from the literal couch, is that now that I am in a house finally, am desperate to get a dog. So that's my like big exciting sort of confession, is that I am looking, I'm waiting till the new year because I'm traveling a lot for the holidays. And then like January 1st, man, I'm going to be going online, looking at all the local shelters and rescues and everything.
Furry couch friend.
So I'm going to have a couch friend. Yes. My couch is too empty right now. So I need a furry couch friend to keep me some company. So
do you
really
have an
excited
idea
about that.
Do you have an idea of what kind of breed you want?
I used to, because a lot of places won't give you a rescue if you live in an apartment or you don't have a yard and stuff. So I used to think I was going to have to actually buy a dog, which is counterintuitive because I really want to do a rescue. So now I'm less about breed per se and more about size and sort of temperament. So I definitely want to do a rescue, looking for sort of like a mid-sized, not too big, mid-sized dog. There's lots of breeds that I like, but it's more about sort of the dog's temperament and looking for the right size. So yeah, so I have that's like my New Year's resolution is to get a dog, which is, I know resolutions are supposed to be hard. That not so much. That's a really exciting one. So.
It is exciting and it's hard. It is hard. It's like kind of
yes. It's work. It'll be a change.
It's definitely work. It is definitely work.
So,
it is definitely, as a single mom of 2 little wieners.
I just love that you call them little wieners.
That's what they are. They're literally 2 little wieners.
I know. It's just so funny.
This is the session of little wieners and hairy balls, apparently. So
thank you for that. Thank you. You just gave us Instagram goals right
I was gonna say that's gonna be the promo for this episode.
I mean, and it's perfect. Boys and eating disorders, wieners and hairy balls.
absolutely. Serendipity at its finest. Oh, this is the uncontrollable laughter.
This is the laugh. Are you going to recover?
No, this isn't the uncontrollable laughter.
Well, that is a perfect foray into our topic of the day, Boys Don't Cry, where Dr. Jason is going to educate us and talk to us about men and boys with disordered eating and negative body image. So we will pass it over to you, sir.
Boys Don't Cry.
Okay, great. Well, I'm really excited to talk about this topic, and I just wanted to start off with a couple of quick caveats. First, because of the position that I'm in, I'll just say that the opinions and assertions that I'm sharing are mine alone, don't necessarily reflect those of the Uniformed Services University or the Department of Defense. Second, what we know about eating disorders and body image, and a lot of what I'll be talking about, is pretty limited, especially compared to what we know in women and girls. And a lot of what I'm going to be discussing is based on information that is largely from Western cultures and cisgender males. And I know that a previous podcast has talked about eating disorders in LGBTQ plus individuals. I'll touch on some issues about diversity and inclusivity in this presentation a little bit later, but just wanted to begin with that caveat. I really wanted to start by asking listeners and viewers to think about sociocultural or societal influences and depictions that are related to men's bodies in Western culture and how that's changed over the last few decades. One of the things that's really changed is increasing attention to male bodies, especially lean and muscular bodies, really in all forms of media, television, movies, magazines, and most recently, social media. And along with that, greater attention to extreme changes or body transformations that really reinforce the idea of a phrase that's one of my favorite phrases is the idea of the infinitely malleable body, the idea that you can change your body and meet body ideals if you just do the right things, which of course is not true for most people. If you go back a couple of decades and think about what leading men, let's say in Hollywood, just as one example, looked like in terms of body types in the 70s and 80s, and then think about some of the bigger stars in the last 10 to 15 years. One of the things that you'll notice is that body types have really changed when it comes to males and what we consider the body ideal for males. And in fact, many of the sort of the leading figures of the 70s and 80s might have what is called pejoratively now a dad bod.
Or even like the 50s and 60s, like I'm thinking James Dean and Bob Dylan, like more lithe bodies.
Absolutely. More lithe bodies. There wasn't really as much of an emphasis on this sort of muscularity and leanness that we see nowadays. And one of the examples that I always like to point to is Hugh Jackman. If you look at Hugh Jackman in the early 2000s, when he first starred as Wolverine in the X-Men movies, he had a very fit body, but not compared to what is sort of expected, particularly of Hollywood heroic actors nowadays. If you compare what Hugh Jackman looked like as Wolverine in the early 2000s versus what he looks like now in the most recent movies, he is way more muscular, way more lean, and that's with 20 to 25 years of aging. So it's really remarkable to see the expectations that have changed even just in the past couple of decades. And the other way that this manifests is in toys. If you look at toys from, 20, 30, 40 years ago of the same characters, so Superman, Batman, some examples of from Star Wars, like Luke Skywalker, Han Solo, etc. The original versions had much more of that, not overly muscular. And then look at the newer versions, and they're much more muscular and have proportions that, if they were life-size, would be unachievable for most human beings. So you see these influences that are really affecting boys from a young age, and they're really likely impacting their body image moving forward and their expectations.
Can I add something to that? My husband works in film and CGI is huge. So for example, Aladdin, the live action one, Will Smith, obviously he's not a blue genie, but he's not nearly as muscular in real life. They blew him up, and that has got to add to the unrealistic standards.
Absolutely. CGI, photoshopping, airbrushing, all of these manipulations that we see in social media, in movies and things, often without any indication that those things have been manipulated. Sometimes it's obvious, other times not so. But again, it can really lead to this perception that everyone can do that if they just do the right things. things, which we know is definitely not true. I wanted to begin with that framework. A couple years ago, I gave a talk that I think is a good broad introduction to this topic. The idea that there are sort of some truths about eating disorders. And this talk that I gave, which I'm going to do in brief format here, is just talk a little bit about some of the truths about eating disorders in boys and men. And really the first one that's important to think about is that when we think about what eating disorders are, the eating disorders field, what the diagnoses are, all of that information came from a history that was very female-centric. And that is true up to probably just, a few decades ago, if not a little more recent than that. That means that much of what we know about eating disorders throughout the times that it's been examined come from essentially young, white, Western, socioeconomically advantaged girls. And so much of the thoughts about eating disorders, the information about eating disorders, all of that.
I was laughing because Courtney was pointing at herself.
Oh, there you go.
Stereotypical girl with an eating disorder.
That is exactly it. So what happens is, because everything was through that lens, it ends up creating what a stereotype is. And the stereotype in the general public, as well as clinicians, especially those who aren't trained in eating disorders or aware of this, leads to misperceptions about who eating disorders affect. And that's true for a lot of different sociodemographic characteristics, but particularly true for boys and men. And because of that, really a very small fraction of research has been done on men. And that means that we know a lot less. Things are getting better, but the history of eating disorders being female-centric led to some stereotypes, misperceptions. It also has fueled some stigma of the idea of males having eating disorders, both stigma from others as well as some internalized stigma. And then it also impacts things like the measures that we use in clinical practice or in research and things like that. When everything has been conceptualized by how things affect women, it may not capture the way that things affect some men in the same way. So the second truth is that boys and men remain under-recognized and underserved. There's an increasing amount of research, but it's still just a fraction compared to what's been done on women and girls. So it's improving, but we have a long ways to go to really understand these things from a research perspective. Clinically, it seems like there's been some progress in terms of males accessing and seeking treatment, but still males represent a fraction of the patient population compared to women and girls. Although evidence does suggest that, eating disorders are truly more common in women and girls, the gender ratio difference is much smaller than what we used to think. A lot more men have eating disorders than we used to think, but unfortunately not enough of them are accessing, seeking, and reaching treatment resources. There's still a long ways to go in that regard.
Can I ask a question about that quickly, Jason?
Yeah.
So I know that I feel like when we see the statistics on eating disorders and I feel like the one that I frequently see is 90% are women. And I think because of my clinical work and because I know the field, I feel like that's pretty erroneous and off. Do you have any thoughts about what you feel like it actually might be? Or do we not know because the assessments are so flawed and targeted more towards females?
Yeah, it's a great question. And that sort of 1 in 10, 90% thing is the long-standing number that a lot of people have heard. Right. And really that derives from historical eating disorder specialty clinics. That was in the past what you might see in those settings. That has changed, I think, more recently. But also what that doesn't reflect is that the people who show up to clinical settings do not represent the general population. And so when you look at general population statistics, there's a lot of variability. It's been estimated 25 to 50% of individuals with eating disorders are men. It varies a little bit depending on the type of eating disorder. Eating disorder tends to have a closer gender ratio compared to anorexia nervosa, for example. But I think the takeaway message is that a substantial percentage, 25, 33, 40, 50% of individuals who have eating disorders, when you're thinking about the general population, are boys or men. It's just that when you get to the clinical setting, there's a lot fewer boys and men presenting compared to girls.
That makes a lot more sense. Thanks for answering that.
And I'll actually touch on a few barriers and considerations for that in just a minute. Related to that, the next truth is that eating disorders can, but don't necessarily present different in boys and men. What that means is that there are a few things that we see that can be different. Oftentimes, boys and men with eating disorders may have more muscularity and leanness oriented attitudes and motivations compared to the traditional weight oriented. So the number on the scale, weight, may not be as important as body shape or leanness or muscularity, being able to see veins, being able to see muscle fibers, things like that. So that can lead to some slightly different ways that these symptoms present. That can also lead to some different behaviors. For example, compensatory behaviors may be more on the exercise side of things, and it may not necessarily look just like traditional cardiovascular or aerobic exercise. There may be a lot more muscle building activities and things of that nature, but it may still have that same sort of rigid, driven, compulsive quality. And then binge eating is one of those things that I think is one of the most complex to think about between men and women, in part because of the concept of loss of control, which is central to binge eating. It's subjective. You have to feel like you've lost control over your eating. And the idea of losing control is counter to masculinity and what masculine norms are in our society. So, and also overeating is perceived differently for men and women. Men also have higher caloric needs typically than women. So it can get a little complicated, and we need a lot more research to understand that. But really thinking about how men might perceive loss of control using different words to try to get at their experience of that sensation.
Well, and I wonder too if it's tied with toxic masculinity when, eating as much as you can is seen as manly. Like my dad is like a total alpha male, and he was a high school wrestler. So he had to gain weight for football and lose weight for wrestling. And he prided himself growing up on being the human garbage disposal. Like he would finish all of our food. And so I wonder if that's also part of it, like the overeating as a sign of I can do this, I'm a man.
Totally. And nowadays there's the concept of cheat meals. So in the bulking and cutting thing where you're attempting to build muscle, but then get lean, there's so many videos on YouTube about these massive cheat meals where, very much to your point, people are essentially bragging or showing off about eating 5,000, 10,000, 20,000 calories in a setting. And it does very much have this sort of overly masculine vibe to it, especially if you're pursuing muscularity, then it's sort of like, look, I can do this. To your point about these behaviors starting, I've worked clinically in the past with men with binge eating disorder who had sort of a similar life history to what you're describing. They, as teenagers and then college students, were athletes and ate large quantities of food, but had a large amount of physical activity. And they were also younger. But then they stop those athletics, get into a more sedentary job, and no longer have that physical activity. But those eating patterns are still there. And then they basically aren't able to change them. They begin experiencing loss of control. Patterns that may not have been perceived as loss of control when they were younger because they weren't trying to control it. But then when they do begin to try to shift things, they're unable to. So that can be a risk factor for binge eating disorder and other types of under controlled eating disorders. Mm-hmm. Yeah. And then the next thing that I wanted to touch on is muscularity oriented disordered eating. And this is another one of those areas. Girls and women, anyone can experience muscularity oriented disordered eating, but it is likely more common in boys and men just because of the differences in body ideals. And these are disordered eating behaviors and practices like over-consuming protein, having extreme rigid rules around building muscle typically. Other things like needing to access food at all times in order to keep one's metabolism going, eating for functionality rather than for pleasure, eating beyond feeling full in order to have a caloric overconsumption in an intentional way to build muscle. The bulking and cutting that I was talking about, where you may be overconsuming at times and then underconsuming at other times to build muscle and then become lean. So all of these patterns look a little bit different. And then the last one that I just wanted to mention was appearance and performance enhancing drug use. And that one being so much more common over the last 10 to 15 years. The number of people who are taking pre-workout and fat burners and creatine and protein and all of these things. Not that a lot of those are inherently problematic, but they can be for people who have risk factors for eating disorders. And particularly for adolescents, we just don't understand the long-term health implications of a lot of these things, which are entirely unregulated in the US. So a lot of times these substances actually have, when they've done laboratory tests, actually have anabolic steroids in them. It can be really concerning and is one of those things that I'd always like to share with people, all the way up to actual steroids or selective androgen receptor modulators that sort of mimic steroids. So a lot of these concerns can lead to behaviors and use of these substances that may have really serious long-term implications for boys and men. And then just very quickly wanted to note, I'm not a physician, boys and men can suffer the same medical complications of eating disorders. Another truth is that eating disorders have a higher mortality rate for boys and men, and they can be severe with severe medical complications. In fact, there's some evidence that boys and men, especially with anorexia nervosa, may present later in the course of their illness and have more severe symptomatology, even if their BMI is not as low because of the differences in body composition. So really important to think about the guidelines and even the BMI criteria. We're all based on women and girls. And so it's really important to attend to potential symptoms in boys before it gets to the more severe state that may see them ending up hospitalized. And then getting back to your other point, two truths that I'm going to combine here are about treatment. And treatment seeking can be really challenging for males because of stigma from society about eating disorders being things that women get. So there may be a lot of shame among men, especially if they feel strongly about masculine norms. And so actually seeking treatment, first of all, recognizing that one has an eating disorder can be an uphill battle for a lot of boys and men. And then second, if you do recognizing it, actually admitting it and seeking help can be a big challenge. And then even when boys and men do recognize and seek treatment, they can face other barriers. Many clinicians may have less experience working with males, which can be a challenge for some patients. If they're seeking treatment at a higher level of care, the programs may not have many, if any, other males that are part of the program, which can lead to feelings of isolation. That can also be challenging for the women and girls who are in those treatment settings to have a male come into those treatment settings for various reasons. So it can be complicated. And we just don't have good research on treatment outcomes for males. What we do know is that generally males seem to do as well as females in our standard treatments, but that's based on a really small amount of evidence. So we just need a lot more information to understand treatment outcomes, and especially if we need to make adjustments to treat males. The last two truths that I'll talk about are just that eating disorders can affect boys and men of all ages and all socio-demographic characteristics. So boys can get eating disorders, adolescents can get eating disorders. There seems to be a special bump in the onset of eating disorders in young adulthood, in transitional time. It may be a lot of other factors that are happening. But also men in midlife and later life can have eating disorders. Again, we don't have a lot of research on it, but certainly we see, especially binge eating disorder, but potentially other things like atypical anorexia may be prominent in men in midlife or later life. And then same goes with other sociodemographic characteristics. We do know that, in fact, some marginalized communities or individuals with historically marginalized identities may be at greater risk for eating disorders, and that includes men, cisgender or transgender men, due to a number of other risk factors, stigma due to their other identities, which may contribute to greater risk for eating disorders. Eating disorders don't discriminate in that regard. They can affect boys and men regardless of socio-demographic characteristics and identities, and also regardless of their body shape and weight. So eating disorders are not just low weight disorders. They affect people across the body weight spectrum, and that is true for boys and men as well. Then the last thing I wanted to touch on is body ideals. I focused a lot talking about lean and muscular body ideals. That's the overarching body ideal in Western society, but body ideals vary a lot among racial and ethnic groups. So not all men pursue or desire a lean and muscular build. There are variety. So it's always important, if you're a clinician working with someone, understanding if you're observing some concerning eating or muscularity oriented or exercise oriented behaviors, what body type they may be pursuing or idealizing.
Well, thanks so much, Dr. Jason. That's so helpful. And, in my private practice, I work with a lot more cisgender gay men, but I do have some cisgender heterosexual men. And all of this information is super, super helpful and even gives me more understanding for them. So I love it. I appreciate it. Well, now let's get into our
Interview the expert.
So, Jason, I always creep on people before I do their interviews. This is a lesson I learned from the great interviewist Terry Gross herself. So I saw that you have 200 publications dating back to 2008.
Naturally.
First of all, that's mind blowing. I have 20 since 2001, and I'm extremely proud of that. You were talking about the dearth of research for men and eating disorders. I mean, you and a few other people are single-handedly filling this void. So what keeps you going? What motivates you? How are you so productive? I need to learn.
Tell us all your secrets.
I appreciate that. Honestly, I'll start with the productivity because I think that leads to sort of the thing that both keeps me going and that is partly why I'm productive. And that's the people that I work with, my collaborators, and just the team effort that is or should be research. So I have a lot of excellent, wonderful, really passionate, really bright, really fun collaborators who I've been working with on eating disorders, body image, and boys and men, and more recently in sexual and gender minorities. I think having a team who is really passionate, who you just enjoy working with, and just shares overlapping but also complementary expertise is really important. If you're a silo, you're not going to get as much done. And you're not going to have the support to do the work, as well as just the intrinsic enjoyment of working with people that you like to work with in writing and developing grants and all of these other things that we do in research.
So speaking of my favorite part of...
Danny,
oh, sorry. Yeah, go ahead.
I gotta go.
You have to go?
I have a patient.
Oh, okay.
Yeah.
Well, if I get to end it,
I'm sorry.
Oh, you're fine. I didn't know you had a patient.
I had to cram. I'm seeing 8 patients today because I didn't do any work.
Well, I love it. Real life. Just me having hot flashes. No, you're fine.
Bye.
Bye.
See a patient.
Okay, bye.
Good to see you, Jason.
Good to see you.
Bye.
Bye.
I forgot what I was just going to say now. She distracted me. So my favorite part of research always was writing, telling a story, weaving the story of what the hypothesis was and how it all comes together. That's literally the only thing I liked. What is your favorite part of research?
Oh, that's a really good question. So again, I would say working with collaborators is probably my favorite part. But in terms of the nitty gritty, I think writing is probably one of my favorite things as well. Writing papers and writing grants, it's just an opportunity to, like you said, tell a story. It's also an opportunity to revisit the literature. So I definitely like that aspect as well of just keeping up with things and learning what's been done most recently, getting motivated by seeing what hasn't been done and really wanting to make sure that the work that I do is contributing in some way, even if it's just basic stuff that's laying the groundwork for the next steps. Yeah, so I think writing both grants, the excitement of getting the money to do the kind of research that I want to do, and then on the flip side of that is getting to share the findings.
And being a full-time researcher is very taxing. It's a lot of hours. It's a lot of, back to the balls, juggling a lot of balls in air. What did you originally envision your perfect career being? And do you feel like you have it?
Great question. I would imagine that being a full-time clinician is similar in different ways.
Love it. I love it. It's easy.
Exactly. One of my best friends that I went to graduate school with is a full-time clinician in private practice, and I'm a full-time researcher. And we constantly talk about how we have such different day-to-day lives, and yet we're both doing exactly what we want to do and probably would not be a good fit for what the other is doing. I moved around a lot for graduate school and internship and postdoc, and the job that I'm in right now, again, full-time research and doing research on populations that are really understudied and unfortunately likely very at risk. I'm doing some work on military individuals now. I'm really excited about my position. My coworkers and the team that I work with is superb and excellent. I am a very people-driven person in lots of different aspects of my life. So having a good supportive team is a really important element. And then getting to do the work that feels like it's impactful or meaningful, addressing issues in populations that have really been understudied really motivates me. So I would say perfect is a very strong word, but I'm very, very happy in the position that I'm in now. I can't really imagine a position that I would like more. I don't know if that means it's perfect, but I'm really excited about what I'm doing now and hope to continue doing it for a long while.
And what led, because I don't think you were in the military, what led to you working for the military? And also, this is also for my son. We're like a very like hippie-ish liberal family. And I know there's stereotypes about the military. My son's dream in life is to go to West Point and be a general in the US Army. So he would love to chat with you about working with military. But was that a population you were driven to work for? Or was it sort of like one of those serendipitous, like you landed this job?
Yeah, it's a great question. I'm not in the military, but I do work at the Uniformed Services University and the Metis Foundation. And much of my work is focused on service members and veterans and their families. And yes, it was primarily happenstance in terms of I was looking for a position at a particular point, and this position became available. I was immediately excited about it because of my interest in boys and men. Approximately 85% or so of active duty service members in the U.S. are men. So it's a very large population of men, and service members are a population that have elevated risk for eating disorders and other related behaviors because they have very strict fitness and weight standards,
And
as well as
PTSD.
other PTSD and stressors and frequent relocations, combat deployments, so many additional potential risk factors. They're just normal human beings that have all of the same risk factors as everyone else. And that's true for both male and female service members. So it was a population that I had not specifically sought out in terms of a research position, but I was really excited about it. And actually I'm just starting up a grant right now that I'm very excited to be doing, that's delving deeply into understanding the nature of eating disorder symptoms and also perceived barriers to recognition and treatment in female service members. I'm hoping to eventually expand that to male service members as well.
So I also know that you are from the South, right? North Carolina?
I am. Yes, I've watching Leslie's talk last week. I went to Duke for undergrad, so
you
that's
did.
my yeah.
And what city did you grow up in?
So I grew up in Durham. I went to high school a couple blocks away from my freshman dorm, pretty much.
Oh my goodness.
Yeah.
How did you decide you wanted to become a psychologist, and like what did your parents do, and what was your nuclear family like growing up, and what did they push you to do?
Yeah, so definitely not. They did not push me to be a psychologist. I came about it sort of in a different way. In terms of family, had a mom and dad, had two sisters, older sisters actually. So they're 12 and 14 years older than me. So in some ways, I almost had like multiple moms sort of as growing up, because
You
they
were
were
like the surprise little baby boy, just like Augie is for Leslie and her two significantly older daughters.
Yep, exactly. A pleasant surprise. That's how I like to think of it. Pretty standard childhood in that regard. Originally, when I went to college, I was pre-med, but I had always been interested in psychology and really had in my mind that I wanted to have good psychological understanding for bedside manner and things of that nature. So I was always a psychology major with a second major in biological anthropology and anatomy. So I've had long names all the way from the start. But I actually did a work study position in a psych lab, actually in a emotion regulation DBT lab, and got really fascinated and interested in that. And then as part of this program that I was doing, I began working in an eating disorder lab. That's where I became interested in emotion regulation and eating disorders, which is my other big research area. It was really the sort of those individual experiences working in a DBT lab and then working in an eating disorder lab. And I just discovered that I really liked psychological research in those topic areas. And so, yeah, I decided to switch gears and pursue clinical psych instead.
Unfortunately, due to technical difficulties, we lost Dr. Jason's feed right here. But Dr. Danny continued to chat with him and got your homework for the week.
Work it, y'all.
Dr. Jason encourages you to check in with the men and boys in your life. If you are watching, the visual on screen has a checklist of potential risk factors. If you are listening, be sure to go to barenakedshrinks.com to download the handouts for this episode.
Awesome. Well, Dr. Jason, it's been amazing having you. This was so fun, and I loved getting to know you better. And I'm sad I won't see you next weekend, but I look forward to seeing you in June. Everyone, stay tuned for our next episode, Rebel Girl, where Dr. Erin Harrop will talk to us about atypical anorexia. See y'all next time.
See y'all next time.